everyone, and welcome to the April 2025 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Mike Rickles from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we are your co-hosts for this podcast series.
Welcome to April, everyone. Let's start out by sharing some fun facts about April. April is named for the Greek goddess of love, Aphrodite. So in some parts of the world, this is now planting time, and in other parts, it turns out to be harvesting time.
And it also represents the month when Passover and Easter are celebrated. And interestingly, I learned this recently, the Thai New Year is also celebrated in April, and I'm going to try to pronounce this properly in Thai, known as Songkran, which is befitting, as the International Diabetes Federation Congress will take place this month in April in Bangkok, Thailand. So I hope to see all of you there.
And that's very fitting, as did you know, Alice, that April is Defeat Diabetes Month in the United States? Very appropriate, as of course, the American Diabetes Association has the prevention and cure of diabetes within its mission, something all of us will continue to strive towards.
I did not know about Defeat Diabetes Month, so thank you for bringing that up, Mike. I think that's going to impact my choices for the rapid exchange that we do later.
Well, here's to continuing all of our missions to prevent and cure diabetes and improve the lives of people affected by diabetes.
And to play our small part, we will, as usual, interview authors of feature articles from April's issue of Diabetes Care and run through our popular rapid exchange segment, where we will each pick 3 articles of particular interest to us.
Let's get on with it. In the April 2025 issue of Diabetes Care is a feature article entitled Management of Diabetes and Hyperglycemia in the Hospital, a systematic review of clinical practice guidelines. I'm delighted to welcome the article's first and last authors, Ms. Linnea Wilson and Dr. Tim Anderson. Ms. Wilson is a clinical research coordinator at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. And Dr. Anderson is an assistant professor of medicine in the Center for Research on Healthcare at the University of Pittsburgh in Pennsylvania. Linnea, Tim, I'm so glad you could both be here.
Thanks so much for having us on, Mike.
Congratulations to you both and your co-authors on this feature article. For starters, can you tell us what prompted your writing group to come together and address the topic of hospital management of diabetes and hyperglycemia and conduct the systematic review?
Absolutely. Our group is heavily drawn from general internists and folks who, provide care for chronic diseases, both in the inpatient and outpatient setting. And that, even since I was a medical resident, has often led me to kind of ask questions around whether we have the same evidence for managing chronic conditions in the hospital as we do when people are at home, in part because this is just so often something that we see patients confused about and sometimes clinicians and learners confused about as well.
So that's great. And your review identified a lot of consensus surrounding monitoring blood glucose in hospitalized patients with diabetes or hyperglycemia and managing elevated glucose levels with a basal bolus insulin regimen, utilizing prandial and correctional insulin doses, and importantly, not relying on sliding scale insulin use alone. And while there seemed to be consensus on the upper limit for targeting glucose being 180 milligrams per deciliter, the lower limit for glucose target varied from around 100 to 140 milligrams per deciliter. So you're right, Tim. I'd say we'd all think there's really not a lot of ambiguity over the outpatient targets for glucose, but in the hospital, there seemed to be a lot of variability. And can you tell us about the source of this variability in recommending a lower acceptable limit for the glucose target when we're managing hospitalized patients?
So without, going into the mind of the folks who wrote the various guidelines that we reviewed, I think a challenge that the guideline writers likely face that leads to this variation is that there really are a very small subset of randomized trials of glucose targets in hospitalized patients, and they're almost all in critically ill patients, either in cardiac intensive care and medical intensive care, surgical intensive care. And yet the guidelines have to extrapolate that out to, regular floor patients as well. One of the things I think that comes up is, how frequently do we monitor these levels? And obviously in the ICU and in these trials, folks were getting their levels monitored hourly or every 2 hours or something. And in an actual floor, that's more like, 3 to 4 times a day. And so ultimately, right, we're trying to balance, just like in the outpatient setting, risks of hypoglycemia with benefits from controlling hyperglycemia. And certainly some of the guidelines, I think, take a little bit more of a conservative approach in terms of allowing slightly higher blood sugars fasting than we might in the outpatient setting, knowing that a lot of patients are going to be not eating regularly, not being allowed to eat at times, or simply kind of being in a physiologic state that doesn't match their normal baseline.
Great. And your article also covered recommendations surrounding particular clinical situations. For example, recommendations for monitoring blood glucose in patients receiving glucocorticoids. But one area that your article did not cover is recommendations for monitoring blood glucose and managing hyperglycemia in patients receiving hyperalimentation, either with total parenteral or enteral nutrition. And so, turn to you, Linnea. What is out there for guiding care in hospitalized patients on TPN or TEN?
Yeah, many of the guidelines that we reviewed did include guidance on these types of nutrition, but that was just a clinical situation that we didn't really get into in the data extraction as we were kind of aiming to understand what's out there for the non critically ill patient. We did collect on nothing by mouth patients to kind of capture the preoperative and other short term disruptions to typical diet. But a lot of the guidance on NPO patients also applied to those on TPN or TEN. And generally, the guidance was, blood sugar checks every 4 to 6 hours and scheduled insulin with correction as needed.
Great. And now, recommendations on what to do with home medications in hospital and how to transition to an outpatient regimen at discharge. That seemed to vary quite a lot in your review. And so, are there any key points to make regarding the transition into and back out of the hospital?
Yeah, so I think into the hospital, what a lot of guidelines focused on was, which home medicines to stop or hold and which to continue with, I think, a consensus that may be shifting over time around, in general, holding oral hypoglycemics. In the era of hypoglycemic medications being used for conditions other than diabetes increasingly frequently, it feels like some of that is changing, but certainly this idea of switching people to basal bolus insulin as one part of the transition into the hospital was very consistent across guidelines. On the other hand, on the transition out, I think one of the things that becomes clear in the guidance is that there is acceptance of a need to have a clear plan in terms of making sure patients kind of return to an outpatient provider who's responsible for managing their blood sugars. But when and who and kind of how that happens is not well specified, both in terms of whether that's something that should be specialty or primary care, as well as kind of how urgent that is. And perhaps that fits clinical practice. Clearly, somebody who's in the hospital for DK probably needs to be seen more quickly than someone who kind of had routine diabetes monitoring while in the hospital. But this idea of kind of what should be part of that discharge education for patients, I think really strongly varied between guidelines, and hopefully maybe is an area that with the next era of guidelines, this can be helpful to guideline writers to reflect on those components, because some really got into the weeds around giving patients instructions on how to monitor their blood sugars at home, on what sorts of equipment we need to really make sure patients don't leave the hospital without, as well as on what sort of education for safety, for example, hypoglycemia education or hypoglycemia home supplies would obviously be really important to patients who are leaving the hospital with a change to their medications. As an internist who does primary care as well, I often tend to still rely on this idea of what happens in the hospital stays in the hospital for most people. And to the extent that we can minimize, confusion with meds or changes to meds when people are coming from hospital to home, that often works most smoothly. And that may be another thing that I think guidelines towards transitions need to think about is, what's the right time to make an adjustment in the hospital versus to kind of make a suggestion to the outpatient docs that when this person who's in the hospital for something that has nothing to do with diabetes is stable, is that really the time to then make long-term changes? And again, that's an area where these guidelines just aren't quite there with consensus, but each one seems to have different, I guess, pearls of wisdom that maybe need to be synthesized.
You're right, Tim, and it's a very different situation when someone with pre-existing diabetes is coming into the hospital, as opposed to where something we've done in the hospital has generated a new onset hyperglycemia, and or is this turning into the beginning of their course with diabetes. And absolutely, it seems like the consensus is individualized education is important, and making sure for that each patient leaving the hospital has clear guidance on what's expected of them in terms of their follow-up and where they're going to be landing. Now, your article brings up continuous glucose monitoring, or CGM, as being recommended in a few guidelines as a continuation of outpatient use for patients familiar with the technology. And we've covered a few studies in this podcast series over the last few years on CGM use in the hospital setting. And I'm interested to hear your thoughts on where we may soon be seeing a shift in consensus regarding CGM use for our hospitalized patients.
Yeah, the use of CGM was inconsistently included in our reviewed guidelines, and it was only really discussed in those published in the past few years, which I think speaks to the increasing use in the hospital, especially as all of those guidelines were published post 2021, and the pandemic brought up a lot of questions about the use of these technologies in the inpatient setting. Primary concerns with them were, malfunctions, mismanagement, or patients losing capacity to use the technology. But as there's been more attention to them, including some inpatient trials, we've seen some emerging evidence of their safe use, which, in conjunction with the improved technology, could contribute to a shifting consensus to the use of CGM in certain inpatient populations. There were some caveats in the guidelines of it should be used in people who have a higher risk of hypoglycemia or who have kind of the capacity to have that self management. So there's still going to be some concerns in that case of who it really applies to.
Right. And again, the message of individualizing a approach is so important. And from your review, what topics for future research would you recommend be prioritized?
While every topic is important in its own right, I see the transition out of the hospital as a priority, as Tim kind of alluded to. Not only was it a topic identified as having little guidance, but it's also a critical point where patients and caretakers are given back the reins after a lot has happened. And so I think getting a better understanding of what education, follow up, and provisions are going to be most beneficial to patients, and then also how to provide those things is imperative to promoting patient safety and confidence as they leave the hospital.
And maybe to add one more to Linnea's is I do think that this concept of where CGM fits in is important because of the fact that there's just this great potential for particularly hypoglycemia reduction more than anything else. And I do wonder about the role for future research, thinking about not just CGM in the hospital, but for that transition. For example, for those folks who really do have, challenging to control diabetes in the hospital, CGM as they go home to really understand how things pan out over like a return to normalcy for them seems like something that could be a really promising area.
Yeah, and that ability for the providers accepting the patients back in the outpatient arena to be able to pull data from the cloud and see what's happening with glucose in the hours and days following discharge can certainly help avert a lot of problems. Any final takeaway messages for our listeners?
So I think, first and foremost, balancing this concept of diabetes as a chronic disease that takes individualized management, I think is really something that the guidelines push. And I always think about the need to really emphasize that over, blood sugar as a number and responding purely to numbers in the hospital. I think the more that we can, as a clinical community, and I think particularly as a kind of central point of the guideline, be thinking about not just the short-term goals of inpatient management, but those long-term goals of how it fits into a patient's chronic disease trajectory is really key.
Well, Miss Linnea Wilson, Dr. Timothy Anderson, thank you both so much for sharing your expertise with us today. I really appreciate all I've learned from your review and our discussion about the management of diabetes and hyperglycemia in the hospital setting. I encourage our listeners to access the full article in the April issue of Diabetes Care.
One of the feature articles from the April 2025 issue of Diabetes Care is a Perspectives in Care entitled The Glycemic Impact of Protein Ingestion in People with Type 1 Diabetes by Dr. Dale Morrison and colleagues. I'm joined today by Dr. Dale Morrison, an exercise physiologist and research fellow at the University of Melbourne as part of the Diabetes Technology Research Group. Thank you very much, Dale, for agreeing to be part of this podcast, and congratulations to you and your colleagues.
Thank you, Alice, and thank you for having me. I'm very excited to be here and for the opportunity to discuss our Perspective in Care article. And we think that our article hopefully can provide some real helpful clinical insights for people with type 1 diabetes and their clinicians.
Excellent, and I'm sure you will. So for people living with type 1 diabetes, we talk a lot about carbohydrates as the primary macronutrient impacting particularly postprandial glucose levels. And usually when we're discussing protein, we do so in the context of its ability to alter how carbohydrates are absorbed. However, your review discusses a whole lot more than that. What was the inspiration to write this Perspectives in Care?
Yeah, that's a great question, Alice. So we wrote this article because we believe that protein as a macronutrient to this point is not usually comprehensively clinically addressed. And we believe that many people with type 1 diabetes and their clinicians sort of lack the appropriate understanding of how protein might impact their glycemia. So currently the literature regarding protein and glycemia in type 1 diabetes is somewhat controversial, and strategies to manage protein ingestion in type 1 diabetes are currently not clear. So there's several factors that we might be able to touch on later which contribute to this general misunderstanding of protein's glycemic effect. And we wanted to provide some clarity around this. Firstly, by providing a comprehensive overview of the physiological mechanisms involved in protein ingestion, and then giving some advice regarding some of the potential clinical implications. And one thing we're really excited about is some of the therapeutic opportunities that protein might present for people living with type 1 diabetes. And we really wanted to highlight these. From my perspective, specifically, I'm really excited about how ingestion of rapidly absorbing protein might be used as a novel way to mitigate hyperglycemia in people with type 1 diabetes.
So you're absolutely right, Dale. As a simple clinician, I can attest to the fact that we certainly do lack knowledge about protein in general. I would say protein ingestion and its effects, and particularly in type 1 diabetes. So thank you for doing this. So let's start with the physiological responses to protein ingestion. And how does that differ between those who live with type 1 diabetes and those who do not have type 1 diabetes?
So this is one of the key areas I think that really contribute to that sort of misunderstanding of the clinical implications of protein in type 1 diabetes, just because the response is so distinct between people who have type 1 diabetes and those who don't. So if we start in the people without type 1 diabetes, so this includes people without diabetes at all, as well as people with type 2 diabetes, protein ingestion simultaneously raises both insulin and glucagon, which synergistically work to stimulate amino acid clearance from the bloodstream into skeletal muscle and the liver, respectively. So importantly, in these people without type 1 diabetes, the combined action of insulin's glucose-lowering effects, along with glucagon's glucose-raising effects, mean that typically in response to protein ingestion alone, blood glucose levels will remain stable. Now, when we add protein to carbohydrate-containing meals in people without type 1 diabetes, this often reduces the postprandial glucose excursions. And this is due to the protein-induced insulin response combined with a slowing of the gastric emptying of the carbohydrate-based nutrients, both of which are mediated by an increased incretin hormone response as well. And as such, protein is typically considered glucose-lowering in people without type 1 diabetes. And so this is probably where a lot of people's minds go to initially when they think about protein in type 1 diabetes as well. However, we know that in people with type 1 diabetes, there's an absolute deficiency in the endogenous insulin response. However, the glucagon response to protein remains intact. And this means when protein's ingested, there's a large and unopposed glucagon response without that simultaneous insulin response. And this is still mediated by the incretin hormone response, which also remains intact. And then along with a large increase in the plasma amino acids, which can be used as a fuel for the liver to produce glucose, this really creates a synergistic physiological environment to increase the body's production of glucose, which means that protein ingestion in type 1 diabetes is actually glucose raising compared to the glucose lowering effect of protein in people without type 1 diabetes.
Okay, so I followed that. You explained that really well. And if I could just recap more for myself, but also perhaps for our audience a bit, you're saying that Protein ingestion results, of course, in an increase in amino acids, but it also can impact and create an increase in incretin hormones, which can then stimulate an increase in glucagon. But typically, that would be offset by an increase in insulin. However, in type 1 diabetes, obviously that part's missing. So then you end up with a net increase in plasma glucose. But it's not entirely that simple, is it? Because I guess it also depends on the protein source itself, not all of them being created equal. So can you expand upon that part?
Yeah, that's right. And I think this is sort of the second area where we can clarify some of the misunderstanding around protein ingestion in type 1 diabetes. So we know that the glycemic index of carbohydrates is really well understood, how different carbohydrate sources result in different glycemic responses. However, the glycemic impact of different protein sources is really poorly understood in comparison. And I think some of the mixed findings and controversy in the literature regarding protein's glycemic impact in type 1 diabetes can be attributed to this misunderstanding of different protein sources. So when it comes to protein and glycemia, both the absorption rate of the ingested protein and the amino acid composition of that protein affect the overall magnitude of response. And so if we start with the absorption rate of the protein, we know that different types of protein influence the rate of gastric emptying, the intestinal transit time, and the accessibility of that protein to digestive enzymes. And all of this means that different proteins absorb at a different rate. The quicker a protein absorbs, the higher the peak amino acid concentration. And we know that the peak amino acid concentration in the blood is the largest determinant of the physiological glucagon response. And there was a really good study from the early 2000s from Calvert and colleagues who demonstrated that the glucagon response to protein ingestion is linearly related to the change in plasma amino acid levels. Now, there is limited evidence regarding the absorption rate or the glycemic impact of common protein sources in type 1 diabetes, but we know that certain protein sources are more rapidly absorbing, and typically the more isolated protein sources that people might associate with protein supplements or protein shakes, like whey protein, pea or soy protein, are absorbed very rapidly, whereas your typical whole protein sources, such as meat, eggs, or fish, absorb quite slowly and might only have a small or sometimes no glycemic impact. Now, to add even more complexity to this situation and some more nuance, in addition to the absorption rate, the amino acid composition is going to impact the glycemic effect. So we know that certain amino acids influence the glucagon response more than others. So amino acids such as alanine, glycine, and arginine in particular have a really potent glucagon response. And this is interesting because it might again explain some of the divergent findings in the literature. So for example, beef actually induces a moderate glucagon response despite being slowly absorbing, and this could be due to the high arginine and glycine content in the beef. All of this being said, unfortunately, to this point, as I mentioned, there's very little data regarding absorption rates and glycemic effects of different protein sources. So I think this is really a key area for future research in type 1 diabetes.
In fact, along those lines, you propose that future research could focus on creating essentially a glycemic index for protein. And I actually love the name that you coined. So what was the name that you coined for that?
Yeah, thanks, Alice. I can't take credit for that one. I think I came up with a few names before we settled on a better one. That might have been one of the other co-authors. But in the article, we suggest developing an aminoglucogenic index. This would be similar to the glycemic index of different carbohydrate sources, but regarding different protein sources and how they might impact glycemia. And I think this would provide some really clinically interesting and important sort of findings for people with type 1 diabetes. And, as I said earlier, the glycemic index, even at the level of the general population, is quite well understood. But to this point, there's really no understanding of that regarding protein. And so if we can develop some evidence regarding the glycemic impact of different protein sources, this will really help us provide specific clinical recommendations for different situations and how to manage glycemia in response to different protein sources in people with type 1 diabetes.
Yeah, that would actually be really quite great because as you're talking about the absorption of protein and that you describe, for example, whey proteins or powders and compared to whole proteins, like for me as a clinician, I could say, okay, that I can differentiate in my mind. But then when you went into the actual amino acid composition, oh my goodness, at that point, I would have absolutely no idea what different protein sources would provide. So if you could create that index, that would be very much appreciated. And along those lines, let's get very practical then. So starting with managing hyperglycemia, how should we then be thinking about protein ingestion in terms of making decisions to help minimize hyperglycemia?
Yeah, so in terms of the current literature in type 1 diabetes, there's actually a reasonable amount of data regarding postprandial glycemic effects when proteins incorporated into glucose containing meals. And so we can provide some real evidence-based recommendations here. And what's really clear when it comes to the glycemic effect of protein is the effect is both moderate and sustained. So protein won't increase blood glucose as rapidly as ingesting carbohydrates will, but it does have a persistent effect that can last for several hours. And again, while we don't know the exact effect of different proteins, we know that very high protein meals with fast absorbing proteins can increase glucose for as long as 12 hours following ingestion. And now, given the sort of high day-to-day variability in glucose levels for people with type 1 diabetes, especially postprandially, the glycemic impact of protein is probably typically overlooked as part of that natural variability or overwhelmed by the influence of carbohydrates in the meal. But we know that the main risk for hyperglycemia following protein ingestion can be 3 or more hours postprandially. And so for this reason, nutritional guidelines from the ADA and from ISPAD have recommended monitoring blood glucose levels for 3 hours following protein ingestion in order to determine if more insulin adjustment might be necessary in that period. Although, again, some more data to further contextualize this for different protein sources would be helpful.
For sure. And to be able to, I guess, predict, right? It's sort of figuring out how many units do I have to bolus for a steak, right? That's the kind of stuff that I don't think we have the details on. But now let's talk on the other side of the spectrum. Let's talk about hypoglycemia. So what role might protein ingestion play in mitigating hypoglycemia in type 1 diabetes?
Yeah, that's a great question. And this is probably the area I'm most interested in, especially with my background as an exercise physiologist and knowing the sort of difficulty people with type 1 diabetes experience around exercise and hypoglycemia. And so, given the sort of clear glycemic stimulatory effect of protein that we've described earlier, specifically fast acting proteins, we believe that these might be viewed not only as a lifestyle factor to manage regarding hyperglycemia postprandially, but something that people with type 1 diabetes might be able to employ proactively as a strategy to mitigate hypoglycemia. And again, given protein's effect isn't as potent as that of carbohydrates, but it is really prolonged, we think it might have really nice utility in specific situations such as long periods of fasting, such as Ramadan, overnight, where a lot of people struggle with hypoglycemia still, and even for long duration exercises. And so to this point, there's actually very little published evidence regarding the use of protein specifically to mitigate hypoglycemia, although the body of evidence is growing. There was a series of studies published in the last couple of years from Muntis and colleagues demonstrating that people with type 1 diabetes who ingest more dietary protein been shown that they have better glycemic outcomes around exercise and less hypoglycemia. There's been some studies showing that protein ingestion post-exercise can potentially mitigate overnight hypoglycemia, and that ingesting a large protein meal as the last meal prior to a long fast with Ramadan can also reduce the incidence of hypoglycemia. And given the lack of research currently in this area, I'm really expecting some really interesting and novel findings across the next few years, hopefully. And we're really interested in specifically investigating how protein can be used with exercise to prevent hypoglycemia.
So that's the perfect segue to my last question then, in terms of where do we go from here? I mean, you've already suggested a number of potential areas of future research. So what are some of the other future research questions?
Yeah, so I think there's a few ways we can address this. So from a physiological perspective, as we mentioned earlier, establishing those absorption rates, glycemic impacts of different proteins, developing that aminoglycogenic index will be really beneficial in improving our decision making and recommendations around protein and diabetes. We're also really interested in physiologically exploring how protein ingestion might affect the alpha cell. So we know that the glucagon response to protein ingestion remains intact, whereas the glucagon response to hypoglycemia or to exercise in people with type 1 diabetes is actually impaired or sometimes even completely absent. There's also preliminary data showing that protein ingestion might actually be able to sort of synergistically restore some of the glucagon counterregulation to stimuli such as exercise and hypoglycemia. We want to look into that more. And it's also been shown that protein might even be able to improve cognitive function during hypoglycemia, which would be an interesting area to explore as well. And then finally, sort of from a clinical perspective, as we already discussed as well, we really need some data around how protein might be used to mitigate hypoglycemia. So I mentioned long periods of fasting, such as Ramadan, overnight would be really interesting as well. And then specifically exercise is an area we're really interested in.
You're going to be a busy man for quite some time, Dale. you and your group. But I mean, who knew protein was so cool? I mean, obviously you did, but I didn't realize there was that much to think about when it came to protein. So thank you very much, Dr. Dale Morrison, for sharing your expertise with us. And congratulations again to you and your colleagues for this comprehensive and thought provoking perspectives in care. And thank you for this great interview where I've really learned a tremendous amount. So I encourage all of our listeners to read the full article in the April issue of Diabetes Care.
Let's move on now to our rapid exchange segment where Alice and I chat about some of the articles we found particularly interesting this month. Alice, what's your first pick?
Well, I'm going to pick up on what we discussed at our intro, the fact that April is Defeat Diabetes Month in the United States. My 3 picks will go along the theme of prediction, and with that, perhaps prevention. My first pick is from Ms. Kirsten Cromie and colleagues from the University of Leeds in the United Kingdom, who looked to define the extent of diabetes risk and explore contributory factors for its development in survivors of childhood and young adult cancers in the United Kingdom. Cancer registration data was linked to electronic healthcare databases, and after a median of 14.4 years of follow-up, 3.8% of the individuals were identified to have diabetes. Total body irradiation increased diabetes risk over time with a 40-year cumulative incidence function, also known as CIF, of 21% compared to only 8.4% for those who did not receive total body irradiation. Hematopoietic stem cell transplant survivors had higher risk with a 40-year CIF of nearly 20% compared to only 8% for those who did not receive this treatment. Allogeneic hematopoietic stem cell transplant survivors also had higher 40-year CIF of diabetes at 25.7% compared to autologous transplant patients at 7.9%. Those who received corticosteroids as part of their treatment regimen also had higher risk. These data help to identify the at-risk population and can inform the development of risk-stratified evidence-based screening for this important group.
Really important, Alice, as with so many advances in cancer treatment, childhood cancer survivors are fortunately becoming a larger proportion of the individuals we see with metabolic disorders, including diabetes, hyperlipidemia, and metabolic dysfunction associated steatotic liver disease. And identifying and mitigating these problems early is so important for improving long-term outcomes. And speaking of identifying a problem early, there's been a lot of attention recently on screening for preclinical type 1 diabetes on the basis that those at highest risk may be candidates for treatment that can delay the onset of clinical diabetes. And because monitoring can prevent presentation with diabetic ketoacidosis and avoid an otherwise life-threatening situation. Dr. John Wentworth from the Royal Melbourne Hospital in Victoria, Australia, and colleagues evaluated results from type 1 diabetes associated autoantibody screening in over 2,000 individuals with a family history of type 1 diabetes. Approximately 1,500 choosing blood spot testing performed at home, and approximately 500 venipuncture having to come in for a laboratory blood draw. Both blood spot and venipuncture-based screening identified an approximately 2% prevalence of multiple autoantibody positivity consistent with early-stage type 1 diabetes. 12 participants did develop clinical diabetes during follow-up, all having screened positive, and none presenting with diabetic ketoacidosis. So use of such in-home blood spot screening holds promise for expanding screening of children and those living in more rural locations.
And I think this interest that you're right has really been over the last, let's say, 5 years or so is warranted because we have all seen people present with diabetic ketoacidosis and often with telltale signs and symptoms for some time prior, but people just didn't know, right? Didn't know what it was. And as you said, DK, could potentially be life-threatening. So if this becomes more broadly available, then we may be able to have nobody present with DK in the future, right? Wouldn't that be something to look forward to? So my second pick is still along the lines of determining risk for development of diabetes. Dr. Zhuanghua Chen, with the first author of Ni Kang and colleagues from the Keck School of Medicine at the University of Southern California, investigated the association between per and polyfluoroalkyl substances, known as PFAS, and changes in diabetes indicators from pregnancy to 12 years post-delivery among women with GDM history. So what is PFAS, you ask? So PFAS are a group of man-made chemicals used in various products that are known for their persistence and are sometimes referred to as forever chemicals. These can be found in a variety of consumer products, including stain-resistant fabrics or carpeting, non-stick cookware, and other products. Although many of these chemicals have been removed from consumer products since the early 2000s, new PFAS chemicals have been created and are more difficult to assess. In fact, a report from the CDC in 2015 demonstrated that PFAS was detectable in the blood of 97% of Americans. In the study in this month's issue of Diabetes Care, 80 Hispanic women with GDM history were followed from third trimester of pregnancy to 12 years post-delivery. Plasma PFAS concentrations were measured at third trimester and first postpartum visit, and oral and intravenous glucose tolerance tests were conducted during follow-up. They found that increased levels, and this is the part that's going to be tricky, Mike, I'm going to try to pronounce some fancy chemicals. So they found that increased levels of MEFOSAA, or methylperfluorooctane sulfonamidoacetic acid.
Very
I hope
good.
somebody's clapping right now. Somebody's clapping, which is a PFAS, was associated with faster increase in fasting glucose. Increased PFNA, or perfluorononanoic acid, and N-PFOA, which is N-perfluorooctanoic acid, were associated with faster increases in fasting insulin and faster decreases in acute insulin response to glucose. They concluded that PFAS exposure is associated with glucose intolerance, insulin resistance, and beta cell dysfunction, increasing the risk of type 2 diabetes.
Well, anything that hard to pronounce can't be too good for you. And
Good
we've
point.
recently covered the increased diabetes risk associated with air pollution. And it's really concerning to think how all of these environmental exposures we have little or no control over, limiting our exposure to, can adversely affect health. Hopefully, these scientific reports can influence how exposure to these potentially toxic chemicals and pollutants are regulated. Okay, so I'll also try to keep to the diabetes risk theme as well, Alice. And we just discussed a simpler tool for type 1 diabetes associated autoantibody screening. And those testing positive with 2 or more autoantibodies next require assessment of glycemia for proper type 1 diabetes disease staging. Dr. Aster Desouté from the Free University of Brussels and colleagues throughout Belgium followed 34 multiple type 1 diabetes associated autoantibody positive first degree relatives twice yearly with collection of hemoglobin A1C, continuous glucose monitoring or CGM, and oral glucose tolerance test or OGTT data for a median 3.5 years. Over this period of time, 17 of these 34 high-risk individuals with multiple autoantibody positivity developed clinical or stage 3 type 1 diabetes. And in longitudinal models, the oral glucose tolerance test-derived glucose area under the curve did outperform hemoglobin A1C and CGM time above range at 140 milligrams per deciliter or 7.8 millimoles per liter for predicting those who progressed to clinical diabetes. Although multivariable models that included both hemoglobin A1C and CGM measures improve prediction and may offer a more convenient strategy for long-term glycemic monitoring than repeated oral glucose tolerance tests.
And I suspect this will be welcomed by the individuals because oral glucose tolerance tests are certainly a pain to do for the individual, having to sit there for the 2 hours and to take the time out and get the venipuncture, etc. So this is an alternative which I think will be quite welcomed. My final pick also fits into the concept of predicting disease, but in this case, not the new onset of diabetes, but rather the prediction of long-term outcomes from diabetes. Dr. Eric Lau and colleagues from the Chinese University of Hong Kong, under the leadership of Professor Juliana Chan, developed the Chinese Diabetes Outcomes Model, also known as CDOM, for predicting incident and recurrent events in type 2 diabetes, including cardiovascular, cerebrovascular, peripheral arterial, kidney, and glycemic outcomes, all site cancers, as well as all-cause mortality. They utilized high-quality patient-level data from the Hong Kong Diabetes Register cohort of over 21,000 people with median follow-up of 7.9 years, representing over 166,000 patient years. The model was externally validated with retrospective territory-wide cohort data of over 176,000 patients. CDOM demonstrated high accuracy in estimating incident and recurrent events in type 2 diabetes relevant to an Asian population. Compared to other models created for a Chinese population, this one is unique for including urine albumin-creatinine ratio, which is an important predictor of end-stage kidney disease, but also heart failure. The authors hope that such a high-quality model will allow for identification of patient subgroups to more precisely design studies, develop tailored treatment strategies, inform policies, and improve cost-effectiveness of diabetes care.
And ultimately, it is the prevention of diabetes complications that serves as the mission for both diabetes prevention and treatment interventions. Another setting for preventing diabetes complications is in the hospital. We heard earlier in this episode from Ms. Linnea Wilson and Dr. Timothy Anderson about their systematic review of clinical practice guidelines for the management of diabetes and hyperglycemia in the hospital. And also in this issue, Dr. Mikkel Olsen from the Copenhagen University Hospital, North Zealand, in Hillerød, Denmark, and colleagues report a randomized controlled trial of in-hospital diabetes management based on CGM or point-of-care glucose testing for individuals with type 2 diabetes. Two centers randomized 166 patients and found that the continuous glucose monitoring, or CGM arm, achieved more time in range 70 to 180 milligrams per deciliter, or 3.9 to 10 millimoles per liter, being 78% compared to 63% in the point of care arm, a remarkable 15 percentage point difference. Importantly, time below range, coefficient of variation, and insulin requirements were reduced, and prolonged hypoglycemia events and in-hospital complications decreased with CGM compared to point-of-care glucose monitoring. These results are likely to have a major impact on the shifting consensus surrounding the use of continuous glucose monitoring for management of diabetes and hyperglycemia in the hospital setting.
And another welcome advancement, I guess is the right word, I think, from a patient perspective, because nobody likes being poked in the finger pretty much ever, but certainly not while you're sick in the hospital. So I think this would be something that the patients will also be appreciative of. Well, this brings us to the end of the April 2025 episode of Diabetes Care on Air. A huge thank you to Dr. Dale Morrison, Ms. Linnea Wilson, and Dr. Timothy Anderson for sharing their expertise with us, and congratulations again for their featured articles.
And a big thank you to you, our listeners, for tuning in. Remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes of this podcast. And thank you for listening.